Good morning and welcome to PCOS, the Hidden Epidemic. Thank you all for joining us. I'm Dr. Pushpa Larson. Our presenter this morning will be Dr. Leah Paz. Please feel free to type in any questions you have during the webinar. Dr. Paz will do her best to answer questions as she goes, and there will be time for questions and answers at the end. Dr. Paz graduated from Bastyr University with her doctorate in naturopathic medicine. She's worked closely with Dr. Jonathan Wright for several years now and has extensive training in the use of bioidentical hormone therapy in both men and women. Dr. Paz is the senior consulting physician here at Meridian Valley Lab and has taught hundreds of doctors around the country to interpret labs and prescribe hormones, as well as training our other consulting physicians. She has co-authored several publications on hormone replacement therapy and food allergies, and she is passionate about helping men and women suffering from the symptoms of hormonal imbalance, menopause, and andropause, and has recently taken on this interest in PCOS and is passionate about that also. So now I'll turn this over to Dr. Paz.
Good morning, everyone. Thank you so much for tuning in. So this is a big subject to tackle, so I just wanted to let you know, certainly this is not fully comprehensive, but I've done my best to touch on all the important points. Certainly I could expand on any of the given points, but I'm trying to give you a good overview of what the syndrome is and what I think the best treatments are. So PCOS is an association of high androgens with chronic anovulation. Without underlying disease of the pituitary or adrenal glands. Somebody is asking to get a copy of the slides after the presentation, and I will go over that at the end of the presentation. You'll all be able to get copies of the slides, so don't worry about having to take copious notes. This whole webinar is going to be archived on our website, the broadcast, and also we will supply you with the slides, and we'll let you know how to do that at the end of the webinar. So originally called Stein-Liebenthal syndrome after the doctors who discovered it about 70 or so years ago, it's really a hormone imbalance characterized by high androgens, and the list you see here: menstrual dysfunction, weight issues, hirsutism, acne, endometrial hyperplasia, diabetes, hyperlipidemia, and metabolic syndrome. The name polycystic ovary syndrome is a little bit misleading because you can have PCOS with or without ovarian cysts, and if you do have ovarian cysts, it doesn't necessarily mean that you have PCOS. The cysts associated with PCOS are actually eggs that don't get released from the ovary because of abnormal hormone levels. So what we're looking at is a very complex clinical syndrome, sort of centering around these three issues: metabolic, reproductive, and psychological issues. And as you can see, they're all very intertwined, and we're going to try to tackle those piece by piece. So is this an epidemic, PCOS? Well, I believe so. It affects millions of women without their knowledge. Estimates range anywhere between 6 and 20% of female reproductive population, and that may be even higher in young women. Infertility is the primary clue that leads to eventual diagnosis. That's what's going to bring the ladies into your office. They're going to probably have been on oral contraceptives for their early years and then come off trying to get pregnant and have issues. It's considered the most common cause of infertility in women today. So young women, like I said, of reproductive age are coming in to the office seeking attention for irregular menses, hirsutism, infertility. This is when they're usually put on oral contraceptives by most conventional docs. The ovarian hyperandrogenism and insulin resistance developed with increased frequency in young girls, especially young girls with early menses. In the early reproductive period, anovulation results in reduced rates of conception, which is why early diagnosis is really key. When pregnancy is achieved, it frequently terminates, unfortunately, in spontaneous first trimester loss and associated with gestational diabetes and also low progesterone. So 25 to 30% of these women show impaired glucose tolerance by age 30, which is very young, and 8% of these women will develop type 2 diabetes. This syndrome has a very long prodrome with detectable abnormalities throughout the life cycle, and the earliest, like I said, would be detectable if we had our eyes open to it. So it's really important, even in our young prepubescent women, to just keep that in the back of your mind. So this is an illustration of just the interrelationship of this clinical syndrome. We've got genetics and lifestyle leading to hormonal changes that is exacerbated by obesity, leading to increased androgens and increased insulin, those are interrelated. High androgens causing hirsutism acne, high insulin leading to diabetes, metabolic syndrome, increased cardiovascular risk. And then we've got the interruption of the follicle development and ovulation, high estrogen, low progesterone, causing menstrual disturbances. And then ultimately this is all leading to psychosocial issues, body image, depression, anxiety. So what causes PCOS? Not sure. Etiology is currently undetermined. There's certainly a hereditary component, like sisters who have PCOS have a 50% chance of having the disorder, so if you, a high correlation between family members. Certainly there's a lifestyle component. Obesity is a big part of that. There's an alteration of gonadotropin releasing hormone secretion, which is resulting in a high LH. High insulin is common and may be one of the causes of the high androgens, and a defect in androgen synthesis that results in increased androgen production. So this is an illustration, a further illustration of what's going on with the hormone signaling. So in PCOS, excess secretion of LH and a deficient secretion of FSH result in abnormal luteinization of the ovarian follicle. The follicles become cystic and secrete androgens instead of progesterone, leading to acne, excessive facial hair, and body hair in a male pattern. Elevated estrogen and deficient progesterone provide negative feedback to further accentuate the LH-FSH imbalance, and typically we consider that around 2 LH to 1 FSH in the PCOS population. One hypothesis in the possible etiology of PCOS involves insulin resistance. Insulin greatly augments the action of LH on steroidogenesis, so that's increasing insulin levels, and that may be the initiating factor contributing to the LH-FSH imbalance. So a little more on the etiology of PCOS. So possibly genetic component. There are a number of proposed genes that can be causing this syndrome, or many genes, and one of them is follistatin, and that plays a role in the development of the ovaries, and it's needed to make insulin. But also poor maternal health, low birth weight, insulin receptor function, ovarian steroidogenesis, and paracrine regulators of ovarian function. So there's a study, and if anybody wants the reference, I can get that to you. I didn't include that on this slide, but there was a study of 50% of women with PCOS or obese and have high androgens. So of this group, half of the sisters also have PCOS and insulin resistance. The other half of the group have insulin resistance with no PCOS or menstrual irregularities. So the clinical evidence suggests a strong familial connection. The location of the gene was on chromosome 19. It's near the same gene that regulates insulin resistance. The genetic marker is associated with increased diabetes risk in both PCOS sisters and brothers. So the male siblings won't, of course, get PCOS, but can have risk of diabetes or insulin resistance. So this may explain the close interconnection between the symptoms found within the PCOS syndrome. They're very differing symptoms. So take-home message basically is the siblings of women with PCOS should be screened for blood sugar dysregulation and insulin resistance, even if asymptomatic. And that goes beyond siblings also. Certainly if parents, if the mother had PCOS, there's a strong possibility that the daughters can also have that. So diagnostic criteria, this has been sort of changing. Currently, the diagnostic criteria involve menstrual irregularity due to oligo or anovulation, clinical evidence of hyperandrogenism, so hirsutism acne, male pattern baldness, or biochemical evidence of hyperandrogenism, elevated androgens, and then exclusion of other disorders like adrenohyperplasia or prolactinemia or prolactinoma. So the minimal criteria include chronic anovulation and hyperandrogenism, and the diagnosis does not require a pelvic ultrasound. So long-term consequences, of course, infertility, spontaneous abortion, depression, anxiety, dyslipidemias, elevated cholesterols, type 2 diabetes, coronary atherosclerosis, cerebral vascular accidents, and endometrial carcinoma. So high androgens due to the excess of androstenedione and testosterone inhibiting follicle development and estradiol production, increasing production of DHT caused by a high 5-alpha reductase, and increasing peripheral conversion of androstenedione to estrone by aromatase. And this is often found in our population of people who have excess adipose tissue because aromatase is largely found in the adipose. So high androgens are going to cause mild acne, mild to severe acne. Hirsutism does occur in 70 to 80% of this population. Increased terminal hair growth in the midline structure, as we saw in a previous slide. Changes in body habitus, waist to hip ratio more than one, causing a android or apple body. Male pattern balding and virilization. Oligoovulation manifests as menstrual irregularity in the early years, occurring in 70% of women. They can also have heavy, unpredictable, prolonged bleeding. And then high androgen production declines as menopause approaches and levels start to normalize. Chronic endometrial proliferation can infrequently result in carcinoma. And so when women are coming in their early, and I've said this before, but I think this is a really important point, women are undiagnosed and not treated properly. They're just put on OCPs to regulate the cycle in their younger years, and this is a missed opportunity to diagnose or treat early diabetes or infertility, which we don't see until they're ready to conceive down the line, and we've sort of already missed the opportunity to reverse some of these things. So the impact of obesity, clearly this is a big causative factor in the syndrome. It has a profound effect on the clinical manifestations. A weight gain is associated with a worsening of symptoms, while weight loss will definitely improve in the disease profile. And a lot of studies have shown that weight loss in women improves the endocrine profile, menstrual cycle, rate of ovulation, and the likelihood of healthy pregnancy. Even a modest loss of between 5 and 10% of total body weight, you can achieve a 30% reduction of central fat, an improvement of insulin sensitivity, and restore ovulation. So clearly this lifestyle modification is a key component of treatment, which we'll talk about in a little bit. More on obesity. It's definitely common in this syndrome. More than 65% of women with PCOS have a BMI greater than 27, and again, the fat distribution is android, and this is causing peripheral conversion of androgens to estrogens, so increasing sex hormone binding globulin, causing more free testosterone, and increased insulin causes an increase in overall androgen production. And then ethnicity definitely influences the weight gain, most common in Hispanic and Black and white women, and less striking in Mediterranean descent and rare obesity in Asian women. But the obesity is likely to facilitate the metabolic abnormalities, of course. Polycystic ovaries, multiple small follicular cysts, and the polycystic ovaries is a misnomer because they're not really cysts, they're interrupted follicles. This is found in 25% of normal women and those with other causes of amenorrhea. 80% of those with high androgens do have polycystic ovaries but may not be present due to use of oral contraceptives. And polycystic ovaries on ultrasound are not necessary for diagnosis, as I said previously. So high insulin and impaired glucose tolerance is showing up in a large population of these women, 25 to 30% by age 30. Insulin resistance does occur in 60 to 80% of women with PCOS and 95% of obese women with PCOS. 8% of these women will develop type 2 diabetes annually. Acanthosis nigricans, darkening of the skin, typically seen in the neck region is often seen with insulin resistance, and there's a strong correlation with high insulin and high androgens. What we're seeing here is a possible polygenic pathology of PCOS. So insulin resistance is important in the development of PCOS, but there's complex interactions that are happening between many systems. This figure here, you can see that insulin resistance and the reacting hyperinsulinemia are responsible for the majority of changes, and essentially all roads lead to increased androgens. You can see that, the increased insulin signaling the pancreas, the liver is decreasing sex hormone binding globulin, of course, causing increased androgens, and also from the gonad and pituitary level having increased LH, causing increased androgens. So hepatic synthesis of sex hormone binding globulin is decreased by higher levels of insulin. Free testosterone is elevated, and studies have indicated that insulin increases as the amplitude of the LH pulse. So the insulin increases the amplitude of LH, and this is causing higher androgens, and this is more so found in obese women, causing more active free testosterone. And so in this population, the total testosterone might actually be normal, but we're having more free testosterone, and also upon urine, when we're looking at urine reports, you definitely will see high testosterone because we're not looking at bound hormone. So a recent study determined, this is more on obesity and insulin resistance, 40% of obese reproductive women with PCOS had impaired glucose tolerance, and 7.5% had diabetes. 15% of normal weight women with PCOS had also had impaired glucose tolerance. So additional studies show an increase in serine phosphorylation at the insulin receptor, causing signaling inhibition. Serine phosphorylation increases the activity of a P450 enzyme in the adrenal and ovarian tissue, and this is increasing androgen synthesis. Research indicates that serine phosphorylation causes insulin resistance in at least 50% of women with PCOS. So somebody asked a question, please clarify, can have normal bound testosterone but excess free? Yes, that's because of the sex hormone binding globulin. There's a decreased sex hormone binding globulin, which is allowing for more free androgens. So again, the question was, how can you have normal bound testosterone but excess free? And that's because we have a decrease in the sex hormone binding globulin, so we don't have that protein to bind up the androgens. They're just sort of floating free and wreaking havoc on the body. So infertility is another big part of this syndrome, which is going to bring a lot of these women into your office. 40% of female infertility results from an ovulation dysfunction. Women with PCOS may experience a wide range of ovulation dysfunction, from oligo to anovulation. They do have a lower rate of conception in response to ovulating-inducing agents like clomiphene and gonadotropins, in comparison to women with amenorrhea but not caused by PCOS. Some studies have described a twofold increase in miscarriage rate in PCOS, and the mechanism is poorly misunderstood. We definitely know it's related to low progesterone and the insulin connection. Cancer risk, certainly there's increased cancer risk. Estrogen proliferates at the endometrium without the opposition of adequate progesterone, which increases the risk of hyperplastic endometrium. And women who have a history of PCOS have a 5 times greater risk of endometrial cancer. Some research also indicates that these women have increased risk for breast cancer as well. Cardiovascular disease is another associated complication. We often see increased lipids and decreased HDL, increased VLDL cholesterol, and a greater atherogenic index in this population. So that's going to suggest subclinical atherosclerotic changes. Although atherosclerosis is not specifically increased, the carotid artery intima media thickness is definitely increased. And then endothelin-1 is a potent vasoconstrictor, and in women with PCOS and high androgens and IR, regardless of BMI, have an elevated endothelin-1. This causes abnormal vascular reactivity, increased injury, and increased risk for cardiovascular disease. So just a review of the signs and symptoms. We've talked about all of these already. And then clinical history and physical exam upon evaluation of the PCOS patient. Certainly we're again looking for the male pattern alopecia acne, acanthosis nigricans, facial hair striae, and virilization. And virilization can present as clitoromegaly or vocal cord thickening, although rare. It's definitely something to keep an eye out for. So evaluation, laboratory evaluation can involve a number of tests. Certainly the test that I think is very diagnostic and very helpful in treatment is 24-hour urinary hormone test. Not only are we looking at estrogen and progesterone, we also are looking at DHEA, testosterone metabolites, adrenals, which certainly are greatly affected by this syndrome, and we're also looking at some indicators of insulin resistance like 5-alpha reductase. So that test alone really can help to treat and to monitor the progression of the syndrome. We're also looking at HCG, TSH, prolactin. You can do a dexamethasone suppression test, or also just looking at the urinary cortisol in the 24-hour urine. We're looking at total and free testosterone, morning progesterone. Fasting glucose and insulin should be measured, although they're definitely not the only thing to look at. We definitely should look at a glucose tolerance insulin resistance test, full fasting cholesterol panel, and definitely a blood viscosity test. The reason we're looking at blood viscosity is because these patients are already at risk for cardiovascular disease. They have, blood sugar issues. Certainly, even without this syndrome, they would be at risk for having thick blood. And so the blood viscosity test is something we do in-house here. And there's going to be more. There's more to learn about that test. I can only just mention it here, but there's a whole other webinar on that subject, and I urge you to look into it because it's great technology. Somebody is asking a question, can you have PCOS without male pattern baldness, etc.? Most definitely. I mean, these symptoms I'm talking about, this is why this is a kind of a hard syndrome to diagnose, is because it's so varied in its presentation. That's why it's a syndrome. So some people don't have any of the, some people don't even have signs of androgen excess. They may not have the hirsutism, the acne, the baldness, not even everybody has insulin resistance. So it's definitely not exclusive. If you don't have these androgen excess symptoms, doesn't mean that you don't have the syndrome. So the American Diabetes Association criteria for diagnosing diabetes or impaired glucose tolerance, which they call prediabetes, is shown here. But as we can see, these recommendations are designed to detect a condition that's already established, not to address prevention, which is what we're trying to do here. Earlier detection of insulin resistance obviously can lead to earlier intervention and prevention. So the glucose tolerance insulin resistance test is something that we do here at the laboratory, and we can very easily supply you in your office with the kit and everything necessary to draw this test. It's very useful. The patient will fast for 8 to 12 hours before the test. A fasting specimen is drawn. The patient consumes 100 milligrams of a glucose challenge drink. Specimens are drawn at 30 minutes, 1 hour, 2 hour, and 3 hours after the glucose challenge, and sometimes fourth is drawn. Glucose and insulin are tested on all specimens, and this classes insulin resistance into patterns by severity. Unfortunately, the fasting blood sugar and insulin miss about 70 to 80% of pre-diabetes, which is why this sort of test is really fantastic at preventative medicine, because we can sort of help that patient before they're in full-blown diabetes, before they have high hemoglobin A1C, before the damage is done. So what we're looking at here, this is the glucose tolerance insulin response test. Based on research, this has identified 6 distinct patterns of insulin response, which you see here, from normal, which is the first, through insulopenic or low insulin, which is the last one. This can allow us to detect insulin resistance long before it would be detected by any of the conventional measures, including the ADA criteria, hemoglobin A1C, or even fasting insulin. For a more in-depth look at this test and insulin resistance, we do have a webinar on our website that was done by Dr. Pushpa Larson that looks at this. So I urge you to take a look into that. It's a very eye-opening webinar and a lot of great information on that. So evaluation can also include pelvic ultrasound. This can be done to aid in the diagnosis and to monitor changes. Cysts are the follicles that have matured but not released, and the diagnosis is confirmed if there are 15 follicles visible in the ovary. An endometrial biopsy would be useful to rule out endometrial hyperplasia if somebody has been amenorrheic for more than 5 months without good reason. So what are our treatment goals? We want to reduce the androgens, we want to improve reproductive function, of course decrease the risk for cancer, promote weight loss, and reduce the risks of insulin resistance. So this condition can be successfully managed with close surveillance, especially a directive approach that prevents potential long-term consequences of chronic anovulation. And then the metabolic abnormalities and treating infertility and improving all the external manifestations of high androgens like hirsutism and acne. Some conventional treatments are oral contraceptives. This is the most efficient means of suppressing androgens because what we see is an increase in sex hormone binding globulin with oral contraceptives, so to bind up all those extra androgens. Let's see, it results in a lower and static LH levels without the surges. The issues with the oral contraceptives is that it can increase insulin resistance. So possibly a better choice may be the Mirena. There's no first pass. It's progestin only. Maybe even adding in some natural progesterone to counteract some of the negative effects of having no progesterone with the blockage of progestin, like increased risk for clot. So that's an option. Spironolactone for decreasing androgens. It's not great for long term. It is used for treatment of hirsutism. Another better option might be a natural 5-alpha reductase inhibitor like zinc or GLA or even oral progesterone. The oral contraceptive population, those people who are in your office, it's really important to screen them for that blood viscosity test that I mentioned earlier because with oral contraceptive they have an increased clotting risk, and so if you have, we've got many factors here: insulin resistance, on oral contraceptives, and increased cardiovascular risk. So they have got this really high risk for clotting and having thick blood. So I think it's really important that this population is screened for that test. There is going to be a whole webinar on this blood viscosity topic coming soon. So it's very exciting technology, and I urge you to keep an eye out for it. Also, there's metformin. Of course, metformin is really fantastic at reducing insulin quickly. It does restore menstrual cycles and ovulation without the aid of fertility drugs. So it's probably the most widely used conventional drug for polycystic ovarian syndrome. Somebody's asking a question about, many patients are on OCPs. What do you recommend for hormone assessment in these situations? I do recommend removing them off the oral contraceptives and putting another contraceptive in place, because certainly when we're looking at urine hormones, we don't test for exogenous estrogens, so it's going to be really hard to look at what their normal, in general it's going to be hard to look at what their normal hormones are because you're putting an exogenous hormone in. So in order to get a good picture, whether you're looking at blood, urine, or saliva, you definitely they should be off the exogenous estrogens so we can see where they are baseline and then tailor our treatments based on that. And oral contraceptives aren't necessarily the best choice for this population. So maybe looking into, like I said, the Mirena, or even a copper IUD plus oral progesterone. There's many, many options here. So if you are going to take your patients off oral contraceptive, I do recommend at least 2 cycles or even 3 cycles off the oral contraceptive, just to give their body a chance to start producing adequate hormone again and regulate. So more conventional treatment, supportive treatment to remove unwanted hair, laser treatment. There's the clomiphene citrate or gonadotropins to help pregnancy. Certainly there are a lot of natural substances, and we're going to talk about those shortly. And then there's the ovarian wedge resection and ovarian drilling, and they have been known to show some long-term effect, but certainly there is a risk, especially with the drilling, with the creating adhesions. It's high on the therapeutic order, definitely not the first thing I would go to. So metformin, a little bit on metformin, just to give you some background. We're going to talk about metformin versus another natural substance. Certainly we all know metformin is successful. It's successful at decreasing, it doesn't stimulate insulin, and it doesn't cause hypoglycemia, and it works. That's what this slide is saying. But we have some other options, which we're going to see in a moment here. So a naturopathic approach would be, of course, lifestyle modification, weight loss, improving diet, low glycemic index carbohydrates, good lean proteins, low saturated fats, high fiber. Exercise is a key component, interval and strength training, and definitely stress reduction. Stress reduction helps to regulate insulin and even cholesterol levels. Cortisol and progesterone can compete for common binding receptors. So reduction in stress can ultimately improve progesterone levels. So as little as 10% of reduction in weight, which I've mentioned previously, it can cause a return in ovulatory cycles and a higher spontaneous pregnancy rate. And there's a global improvement of overall health, including cardiovascular, metabolic, and menstrual. The problem is the compliance. Of course, this is the hardest treatment area. And weight loss will improve body image, reduce depression, and restore a sense of control. And programs that targeted this issue alone, weight loss alone, have achieved a pregnancy rate as high as 60% without medical intervention. And that is, it's really wonderful. It's not giving them an additional pill or supplement to take. It's really just helping them to achieve better fitness and better dietary goals. So more on naturopathic treatment. Fiber, calcium, and vitamin D are going to help with hormonal balance. NAC has been shown to promote insulin sensitivity and increase ovulation and pregnancy in PCOS women, as women who were, in one study, who were resistant to clomiphene treatment. Essential fatty acids can slow down the absorption of carbs in the blood. And then we've got the D-chiroinositol, pentothal, myo-inositol, all related B vitamin supplements. Women with PCOS are believed to have a deficiency in this, causing insulin resistance and hyperinsulinemia. So supplementation is definitely going to improve action. So further treatment, these are some nutrients for blood sugar dysregulation or insulin resistance, just a whole host of good vitamins and minerals. And at the bottom you'll see again there D-pentothal, but the myo-inositol is probably the preferred form of the pentothal or D-chiroinositol. Somebody is asking me, can you combine progesterone with an oral contraceptive? And yes, most definitely you can. In some cases it's recommended. And again, I mentioned previously to sort of negate some of the negative progestin side effects, putting in some natural progesterone is sometimes a really great thing. But again, there are other ways to combat the high androgens other than using the oral contraceptive, and we're going to talk about that in a moment or so. So I think that certainly combining natural progesterone with oral contraceptive is a good option, but you can also just eliminate the oral contraceptive, find like a copper IUD or a Mirena or something that's eliminating that first pass. And oral contraceptives, oral estrogen definitely does provide some risks, including cardiovascular risks, clotting risks, and so we already are having these risks in this population aside from being on oral contraceptives, so I think there's maybe another option. Okay, moving on. So we're talking about berberine now in the treatment of type 2 diabetes. This is one study that was done with newly diagnosed people with type 2 diabetes. 36 adults were given either metformin 500 milligrams. So 500 milligrams TID or berberine 500 milligrams TID. And what we found was, compared with metformin, berberine exhibited an identical effect in the regulation of glucose metabolism, hemoglobin A1C, fasting insulin, and postprandial insulin. But also, in the regulation of lipid metabolism, berberine activity is better than metformin. So by week 13, triglycerides and total cholesterol in the berberine group had decreased and were significantly lower in the metformin group. So the take-home message is that berberine is a really great option for this population or any population with insulin resistance. Another study involving PCOS and insulin resistance and berberine, 89 women, 3 treatment groups, one with berberine and an androgen blocker, the other with metformin and an androgen blocker, and then placebo plus the androgen blocker. And what we found was in comparison to placebo, berberine produced a decrease in waist to hip ratio, fasting glucose, fasting insulin, total cholesterol, LDL, and triglycerides, and an increase in HDL and sex hormone binding globulin. So overall, certainly better than placebo, which is what we would expect, but how is it compared to metformin? Basically, compared to metformin, it had the same, if not better, effects. So decreased waist to hip ratio, decreased total cholesterol and triglycerides and LDL, and increased HDL and sex hormone binding globulin. So the take-home message is 500 milligrams of berberine TID is fantastic in treating insulin resistance related to PCOS or in the general population. So here are some herbs that we use with this population. We've got bitter melon and gymnema to improve blood sugar. Urtica or stinging nettle is going to help to decrease bioavailable androgen, and the way that does that is that it causes so the lignans from the nettle bind to the sex hormone binding globulin competitively, causing an increase in circulating sex hormone binding globulin, which is providing a relative decrease in bioavailable androgens are all bound up by the newly formed sex hormone binding globulin. Saw palmetto is a great option for the hirsutism and the acne. It inhibits 5-alpha reductase. Licorice decreases serum testosterone. Spearmint, 3 cups of spearmint tea per day can lower testosterone levels and subjectively has reduced hirsutism. And the maitake mushroom helps to regulate menses and induce ovulation. So progesterone support certainly needed. Vitex is one great herb to use, wild yam, and then sesame and sunflower seed, the seed rotation diet. Of course, having adequate cholesterol. Some supplements may include pregnenolone, maybe HCG, endocrine granular products. Someone's asking, will a downloadable version of the slides be made available? Yes. So at the end of this presentation, I'm going to tell you how to get the slides. Natural progesterone is another fantastic option. It's proven effective in inducing fertility when there appears to be some sort of ovulation dysfunction. Evidence indicates that natural progesterone therapy poses no risk, and it's likely to benefit those who wish to become pregnant. And it helps maintain pregnancy through the early months. And certainly, giving progesterone through the first trimester is very beneficial and safe, and helps a lot of women in this population to achieve pregnancy. So now I have one quick case to talk to you about. Madeline, a 31-year-old woman with PCOS. There's a typo there, sorry about that. 31-year-old woman with amenorrhea of 151 days, desiring pregnancy. She's got irregular cycles since puberty. She was put on birth control to regulate cycles. She was diagnosed PCOS by a gynecologist a couple years ago through lab work and ultrasound. She's charting her cycles, and she does note that there are some signs of fertility, but her period starts brown clotted and then bright red for 4 days, and 1 to 2 days of spotting, and she's never been pregnant before. She's not currently on any medications. She does note that she has a sensitivity to wheat, but she's not avoiding it, and she's also sensitive to MSG. She has a history of eczema and scalp on the neck, on the scalp and on the neck. Her vitals look pretty good. She is a little bit overweight, BMI of 27.1. She does have clear skin, meaning no acne, and a normal hair distribution. All other systems are within the normal limits. Someone's asking me, can natural progesterone benefit those who do not wish to become pregnant? Most definitely. That's not only a treatment for those wishing to achieve pregnancy. Ultimately, there's a deficit in progesterone in this population. Progesterone has lots and lots of benefits beyond achieving pregnancy, including ability to sleep, of course, having a normal menses, a sense of calm. There's so many functions of progesterone. So certainly, it's not only for our population wishing to achieve pregnancy. Somebody was asking a question about berberine and how long to take it. So some trials showed a benefit in 3 months, so at least 3 months on berberine. May have earlier results, but at least 3 months, at least on 3 months, and there is no risk to taking it long term. Back to the case here. So Madeline came in with her ultrasound. What was found were multiple uniform peripheral follicles in the central ovarian stroma, about 6 to 7 millimeters bilaterally. The assessment, the primary assessment, is that she's got a mild mineral imbalance and tending towards low trace minerals. We did a mineral test on her, but did not show it in this presentation. She does have menstrual irregularity, digestive and sugar handling problems proposed. Hormone balance and fatigue are her main concerns, of course, wanting to achieve pregnancy. So our initial plan is to work on her diet and exercise. As we know already, that's an issue. Gave her some supplements, some help with blood sugar, some help with progesterone, asking her to continue charting her basal body temperature. And then we did give her a 24-hour urine hormone evaluation kit to take home, and this is some key points on the urine test. It provides a complete look at levels. It's gold standard for growth hormone. It's really good at looking at metabolites, pathways, great correlation between symptoms and lab values, and it's really great in monitoring treatment. So sent home with the kit, which you see here, 24-hour urine kit. Also sent her home with an allergy kit. In the office, we drew her for some normal blood work, lipid, glucose, insulin, CBC. We also did a blood viscosity test on her and wanted her to come back in 1 month to review labs. This is what we found on her lab values. She definitely has got some liver issue going on. High cholesterol, moderately high, and then high triglycerides, low vitamin D, high MCV, so maybe a B12 folic acid deficiency, and certainly high blood sugar. So it's a good thing that we got working on that early. This is her 24-hour urine report. So what we're looking at here, she's got low normal estrogens overall. You can see her total estrogens are 28. For this this age woman, she should be maybe closer to 30 or between 30 and 50, so she's a little bit low. But her estrogen metabolization looks very good. She's got very low progesterone at 332. Normal would be closer to 2 or 4,000. Her androgens are very, very high. You can see everything is flagged as high there. And again, this is just part of the syndrome, so we're going to work on treating that. She definitely has overactive adrenals. And in this population, adrenal androgen synthesis is increased 26%. And total cortisol metabolites, which you see here, they're high at 8,664. Normal is closer to between 5 and 7,000. So she's high, and we do notice that this is something that happens across this population to have normal metabolites. High metabolites. Thankfully, she's got good-looking thyroid levels. Those are right in the optimal range. She does have a high sodium-potassium ratio, so we're going to work on that dietarily, work on getting her some more leafy green veggies and coconut water, things that have sodium and potassium, or things that have potassium in them. Somebody just asked, what day of the cycle is this test? Thank you for asking me that, because I forgot to mention that we do it in peak luteal phase. So we want to do it, you know, a normal cycling woman, we would say day 18 through 21. So we did it in that range for this particular patient. Even though she didn't have a normal cycle, she is noting signs of fertility, so we were able to determine when this test was done. She is having some ovulatory cycles. And then lastly, we're looking at enzymes, and I mentioned previously in this presentation 5-alpha reductase is elevated in these women, causing a high DHT, high 5-alpha dihydrotestosterone, which is causing the acne, the hirsutism. Of course, there's definitely a correlation with PCOS and insulin resistance, so we're going to work on that as well. And traditionally, this is where spironolactone is coming into play, but we're not going to make that option. We're going to go for natural substances like zinc or GLA, and even the progesterone will inhibit 5-alpha reductase. So our assessment is definitely she's got a hormone imbalance consistent with PCOS with low progesterone. She's got high blood sugar, liver enzyme issue, low vitamin D, B12 folate deficiency, and food allergies. Somebody's asking me when to test with women who have inconsistent cycles. It's probably the toughest thing to do, is to determine when to test. If the woman is ovulating, you can definitely get an ovulation monitor. You can get those at the drugstore and try to determine when ovulation is happening, and then you do it a few days after ovulation. Otherwise, you're just looking for a time that you're looking for a likely time that they would be in peak luteal phase. So it's kind of a little bit of a guessing game. But the other thing with this population is that any time in the cycle, they're likely to have high androgens and low progesterone. So even if you don't catch them in the peak luteal phase, it's still going to give you a lot of information. And you'll always see the high 5-alpha reductase as well. So the plan for Madeline is to continue supplementation, add in some progesterone support with the Vitex, and we did eventually add in oral progesterone. Add berberine, 500 milligrams TID. She's going to diligently follow her eating plan. She's going to keep trying to get pregnant. She's going to return in 3 months. And the update on this patient is she just actually delivered a baby a couple of weeks ago, and so she did achieve pregnancy. It did take her a little while. She did get her blood sugar under control and was on the progesterone, and she did have to be on the progesterone through her first trimester, so she did need that support. Somebody's asking me a question. Are women in menopause more difficult to treat? Can facial hair still be reversed and insulin balanced in the 50-plus population? Most definitely. I wouldn't say women in menopause are more difficult to treat. I would actually say they're a little bit easier to treat because we're not trying to achieve pregnancy, and you know, balancing the hormones is a little bit easier because we are giving bioidentical natural hormones, and we have a little more control. Rather, in the younger population, we're trying to treat the cause, you know, and try to reverse the high androgens, and we're working on maybe at a more fundamental level. In menopause, we're doing the same things, but I think we can achieve better outcomes quicker because we would be giving hormones if that's what the patient wishes to do. But the insulin can be balanced the same way we would balance insulin in a younger population. And then the facial hair, you know, it's not a hard thing to fix. It's giving zinc, giving progesterone, giving gamma-linolenic acid, evening primrose, borage oil. Those sorts of things are all going to inhibit saw palmetto, inhibit 5-alpha reductase. So I wouldn't say menopausal women are any more difficult. If anything, maybe a little bit easier to treat. So take-home message here is, in conclusion, it's really important to take seriously the early warning signs of PCOS. The consequences of not intervening may predispose the patient to developing diabetes and cardiovascular disease down the road. It's a complex condition. We all know that. Lots of varied symptoms. It's often undetectable or misdiagnosed, so keep your eyes open. Even in our younger population, early detection and prevention is key, and there are lots of effective natural treatments. We don't have to rely on the conventional metformin and OCPs. There are other options. I'm not saying that that's not good for some people, but just know that there are many other options that we can take into consideration. Somebody's asking me if I had to use birth control pills, which birth control pill would I use, and I would prefer not to use an oral form because there's a lot of risks with oral estrogen, so I would use the Mirena, Progestin, IUD if I was using something hormonal. Or if I were going to use an oral, I would probably use low estrin, something with just really low progestin. That would be my option. Somebody is asking, can alterations be made for those dealing with breast cancer in menopause, whether or not they're doing traditional or alternative means of cancer treatment? So a woman who has PCOS and breast cancer, there's many things we can do to augment hormones without using hormones in a menopausal population or in a young population. So certainly many women are being treated with breast cancer in a menopausal age and using alternative medicine. And certainly some survivors of breast cancer are interested in being on hormones, some are not. So there are a lot of options for that population as well. Let me see. I'm looking to see other questions. Do I use any other traditional female herbs? Yes, when women have, in this population, when women have low estrogen, definitely I'm looking at soy, I'm looking at Dioscorea and Dong Quai, and certainly depending on what we need to treat. But yes, I do use also, I already mentioned wild yam for progesterone and astragalus, and I did mention Vitex previously, but also in the interest in decreasing cortisol production, we can look at magnolia bark is really great at decreasing cortisol. Also phosphatidylserine, which isn't an herb, but if we want to ultimately decrease the cortisol secretion and production and help with sleep. So lots of options herbally. Let's see. Somebody asked the question, why is LH going male instead of female in these patients? So when LH is not synchronized with FSH to generate an LH peak, it can cause abnormal follicle development. So follicles produce androgens instead of progesterone. So it's a malfunction of the feedback, and like we said before, the increased insulin is increasing the LH surge. So it's all very interconnected in terms of the LH secretion and why there's so many androgens. So the question is, someone else has a question, do you need more FSH? Well, the FSH is either normal or low in this population. So I think rather the treatment is to decrease the LH versus bringing up the FSH. Let me see. Somebody has another question here. Okay, so yes, I have a question about, in your opinion, do you feel it's risky to use Vitex with hormonal contraception in women, relying on that form of contraceptive for birth control? I've read some warnings against using Vitex because of its ability to alter hormone levels. Yes, I think that I agree. I think that when we're working in a population that is not trying to achieve pregnancy, we definitely need to be more careful. You don't want to render birth control ineffective by using herbs. So I think primarily you would definitely work on treating the underlying diseases and maybe not giving the Vitex or something that's going to disrupt the birth control. But again, there's also copper IUD and barrier method, and there's other options, but I would not want to interfere with the birth control or cause it to fail and be the cause of an unwanted pregnancy. So certainly I think that you have to be very careful in that situation. Someone's asking if powdered inositol is safe. As far as I know, powdered inositol is safe. I haven't heard anything otherwise. Somebody's asking, in what length of time will you repeat the test? I say at least 6 months. You need to give 6 months to instigate treatment and have some change really take place before you repeat the test. You can consider 3 to 6 months, but if we're looking at saving the patient money, I might say 6 months versus 3 months. If we're talking about blood viscosity, we're going to want to do blood viscosity much sooner if it's high. If we're talking about the urine test, 3 to 6 months. If we're talking about blood viscosity, we're talking 6 weeks. Because if blood viscosity is high, that's putting them at risk for stroke and other cardiovascular events, and you want to treat that as soon as possible. And like I said, there's going to be there's a webinar on that, and it involves fish oil and hydration and all that sort of thing to decrease the viscosity of the blood. So let's see. So another thing that's important to mention, you may want to decrease or discontinue berberine when pregnancy is achieved because there's a small risk in bringing on miscarriage. So I might look at other options for controlling the insulin resistance once pregnancy is achieved. Are there any other questions? Somebody's mentioning the liver is the main organ that if I correct will correct. Liver is the main organ that if corrected will correct. Yes, I agree with that. So how do we get the slides? So to get a PDF copy of today's presentation, we're going to send you an email. Open the email, click on the link for the survey, complete the survey, and submit it online, and then we'll send you the PDF copy of the slides. And the webinar, this broadcast, will be archived on our website shortly. We just need to get it up and running, and that's usually at least, a week or so, week to 10 days. Is cod liver oil good to take for vitamin D? I would probably choose if you have very low, it's definitely a good source of vitamin D, but if you have low vitamin D, I would probably take a micellized vitamin D that has 2,000 IUs of vitamin D per drop so that you can get a greater effect. But cod liver oil is a nice daily maintenance, but if you have a deficit in vitamin D, it's going to take you a long time to get your levels back up. Somebody's asking how much of a factor is somnolence with progesterone use? Well, it's different for everybody. So I think if you give someone progesterone if a sustained release and they're tired all day, then maybe you need to change that to oral micronized progesterone at bedtime. And some people are more more responsive than others, and some people don't have any reactivity at all to progesterone in terms of a sleep-like effect. Certainly if they are very sleepy on progesterone, I might switch from an oral to a topical form. There's definitely less of the pass through the liver, so there's less allopregnanolone, so there's less of the GABA effect. Somebody's saying 2,000 D3 will bump up the serum level. How much? Well, it all depends on so many factors. It depends on how low your level is, how long you're taking it. That's a question that's hard to answer. How can you get the testing you mentioned if your doctor doesn't know about it or do it? It's a great question. What I recommend you do is tell your doctor about, we have some brochures that are available to give the doctor, but also you can just tell your doctor about, you can direct your doctor to our website. They can watch this webinar if they so wish. All they have to do is, it doesn't cost any money to sign up for an account, so they could just sign up for an account, learn about the testing, and if you are an advocate for your own health and you say, I would really like this test, I think it is really going to serve me in my health, then hopefully they'll be able to hear that and they would be willing to learn about the testing. And I definitely recommend being your own advocate because sometimes, we all need to be our own health advocates. The doctor is there to help, but you need to be an advocate for your own health. Progesterone dosage premenopausally, someone's asking that. It can vary from 30 milligrams to 200 milligrams, second half of the cycle. It just depends on the patient's levels and if they're trying to achieve pregnancy or not. Certainly if they're, if you're treating someone in their first trimester and they're trying to maintain pregnancy, we're talking upper ends like 200 or so, but it really varies on the person how much deficit of progesterone they have. There isn't one dose that's good for everyone. Anyone else have any questions? So back to the person who's asking about, if your doctor doesn't know about the testing and doesn't do it, certainly I urge you to talk to your doctor, but if your doctor is not willing to take on a new type of testing or doesn't have the time, you can give us a call, and our customer service team is happy to connect you with a doctor in your area that does do our testing, so we can hook you up one way or another. Any other questions? So we are going to be having another webinar by Dr. Michael Kaplan. He's going to be doing a webinar on testosterone and the prostate, and that's coming in September 6th. I think that's a Thursday. All right, well, thank you very much. If there's no more questions, I'm going to say goodbye, and thank you very much for tuning in, and we look forward to hearing your feedback. Please take the survey, and if you have any follow-up questions, you're welcome to contact the customer service team and ask us about how you can order a test for yourself or for your patients, and I hope you have a good rest of the week.